There we go. Got it. So anyway, Director of Referrals and Admissions at On With Life. I'm Angie Jackson, and I have the pleasure of introducing our next speaker today. Laura Werley, she is the Director of Physical Therapy at Craig Hospital in Inglewood, Colorado. She began her career at Mount Sinai in New York in 2000 before making the move to Denver in 2004 to pursue her passion for spinal cord injury rehabilitation. Thank you, Laura, for coming out here today, and we'll let you take it.
Great. Hello, everyone. Thanks so much for having me here today. I'm so excited to share my passion for treating individuals with spinal cord injury with you. I understand that On With Life is interested in taking on more individuals with spinal cord injury, and so hopefully this will just scratch the surface of information that may be helpful for you as you treat individuals with spinal cord injury. I'm curious, I saw the list of everyone that's here, but I'm curious as to how many of you have worked with an individual with a spinal cord injury in the past? Excellent, a lot of us. Keep your hands up if you work with someone with a spinal cord injury on a couple of times a year. All right, and we're gonna go, well, I should probably start with how many of you work with someone with a spinal cord injury daily on your caseload every day? Wonderful. How about a couple of times a week? A few times a month, maybe? And how about a few times a year? All right, we've got a variety of experience. That really helps me to know more about your experience as well. As Angie said, I've been at Craig Hospital about 19 years. Before that, I was at Mount Sinai, where I kind of fell into neuro rehab and spinal cord injury. I didn't know that that's where I was gonna end up, and fell in love with it. And I followed my passion to Craig, and really have spent most of my career, about 95% of my career, working with individuals with spinal cord injury on the inpatient side of rehab. And so I have also been doing some teaching with a company called Spinal Cord Injury Seminars, and so I need to give credit to them as well, which I will in the next slide. So a few objectives today. Probably a lot to cover in an hour, but I will do my best to give you the high points of looking at some secondary complications that we should be aware of. Also looking at some interventions and hopefully giving you some tips and tricks. And then also I'd love to at least touch on the idea of an answer to some of these hard questions that our patients with spinal cord injury ask. So, and I will stop myself too, I learned about your person-served terminology yesterday, and so I will ask you to excuse me as I do refer to individuals as patients, but hopefully, and individuals with spinal cord injury, but excuse my lack of person-served terminology. So as I mentioned, I taught for about 15 years as my second job in continuing education with SCI seminars, and I do need to give them a plug because I'm using some of the videos from that company. And I just wanted to also point out some resources that are available at sciseminars.com. There's a resources page. There are some YouTube videos that we've picked out from YouTube. You can see all sorts of types of videos on YouTube and some things that I might not recommend, but we've made a list of things that maybe you could look at to see what is maybe some good movement strategies and tips and tricks there. There's also a list of resources and references too that may be helpful as you're looking into treating individuals with spinal cord injury. So I imagine that a lot of you have been outside of a room meeting an individual that you are going to work with, and you read their chart and try to get to know them as a bit through their history and see that they have a spinal cord injury. And that may be intimidating. I know it was for me when I first started, not knowing where do I start with this? What do I do? What do I focus on? And where do we go from here? And so my first approach is really to get to know the patient themselves, the person. What is their story? What brought them here? And really try to identify with what maybe their goals might be, what are their interests, and get to know them as a person. And then also looking at the more clinical side of things, I really am interested in their diagnosis. The we'll talk a little bit about what that means and the INSCI exam that can be done. That helps me to understand how their injury is presenting, and then also to understand a little bit better what their prognosis might be. I want to be aware of some medical complications, of course, to be alerted to, because as therapists, we typically are the ones who are spending the most time with people, and we may see some of these signs and symptoms that maybe we can let the medical staff know about and be aware of. And then treatment progression. And so hopefully I'll share with you some helpful tips and tricks. So as far as diagnosis, we really rely in the spinal cord injury world on INSCI, and that is the International Standards for Neurological Classification of Spinal Cord Injury. I realize that does not spell INSCI, but that is what we say to keep it short. It used to be called the ASIA exam because American Spinal Injury Association is who developed it, but they also have a lot of other exams available now. And so to call it the ASIA exam didn't allow them to identify all the other exams that are available now. With the WE-STEP, there's a spasticity and autonomic function exams now. And so it is called, we refer to it as INSCI. Doesn't quite roll off the tongue as well as ASIA, but we are adjusting to that. So the ASIA Learning Center is a great resource for you. They have the INSCI exam sheets, sensory and motor guides, and quite a few modules that they say take about 6 hours to learn how to do this exam. I would say it probably doesn't take quite that long, but there's a lot of great resources available at the ASIA Learning Center. And then there's a great INSCI calculator available at inscialgorithm.com. If you ever have those data sheets, which I think is next here, if you see this type of data sheet coming with your individual's data on it, you can put in that data into the classification algorithm and it will calculate those values for you. So it's quite complicated to actually calculate those yourself, and you can learn that, but the calculator is a great double check. So you can see here that this is some of the data that we're collecting on our individuals with spinal cord injury, sensory scores, which you'll see in those middle 4 columns. Those run from 0 to 2. So 0 means absent, 2 means intact, and a 1 is that it's impaired. It's not the same as their face, which we use as the foundation to determine what's normal and abnormal. And so 0 absent, 1 impaired, and 2 is intact. Then we also look at strength. Now strength, a lot of the therapists here will know about manual muscle testing. It is a little bit different than manual muscle testing. There's no pluses or minuses. It's just whole numbers, and it's really to determine if the nerve root is neurologically intact. It's not really about strength. We're using strength to make that judgment about whether that nerve root is intact. And then we gather all this information, and at the bottom, we're able to come up with a diagnosis. Now, one of the most important aspects of the diagnosis is that bottom line where maybe you can see NOON. And I don't know, at the bottom you can see there, it's quite tiny, and I'll actually think I have blown it up a little bit here. So we have a very important row at the bottom of your INSCI exam that looks at voluntary anal contraction, sensory at S4-5, which is right around the rectum, and the presence or absence of deep anal pressure. And so this is the most important part of the exam from a prognosis standpoint, and from your diagnosis standpoint. That tells you whether the person has a complete versus incomplete injury. So if there is what we call a Noon sign, N-O-O-O-O-N, that means that the individual has an AIS-A or complete injury. If they don't have a Noon sign, then they would be considered to be incomplete, and then we can determine whether they are just sensory incomplete or sensory and motor incomplete. And this is the most important long-term prognostic indicator, is whether someone is complete versus incomplete. So just to walk you through the other ASIA levels, or AIS-A, AIS-B, C, or D, AIS-A is motor and sensory complete. AIS-B means that they have some sensation some sensation at that S4-5 level, and possibly below that, but no motor. AIS-C means that they have sensation and or motor at that S4-5 level, but it's not really functional movement. So it's usually most of those muscles are less than a 3 out of 5. So for those of us therapists in the room, and know that that will give you some strength, but you're probably not going to be doing a lot of independent ambulating. But AIS-D means that you have 50% or more of those muscles below that neurologic level of injury are a 3 or greater. And so that is more functional movement. So when we see in the literature that we hear someone is motor incomplete, we're really talking about those AIS-C and D injuries. So what does this mean and how can we use this? Well, the predictability can be based off of a lot of the information that we get on the INSCI exam. And so the first predictor is the severity of the injury. So the AIS level really helps predict how serious that injury is. You see the most neurologic recovery in individuals with AIS-C injuries, so they have some motor function after their initial injury pretty early on, within 72 hours to a week after their injury. And if they're AIS-C, you're going to see the most recovery. AIS-B is next, and so we often see conversion from a B, which is sensory incomplete, to a C, or sometimes progressing to a D, which is great. Ds tend to see less motor recovery, but that's because we think they start with more function to begin with, so there's more of a ceiling. And so we see less overall motor recovery with AIS-D because they start out so strong. And then unfortunately, AIS-A, we still see that has the least amount of neuro recovery. Different studies will indicate that anyone with an AIS-A injury may convert to an AIS-C. About 5% of individuals convert to AIS-C, and only 3% convert to AIS-D. So unfortunately, we still need lots of research and innovation to be able to address those individuals with a complete injury. If the individual is less than 50 years at the time of injury, that is a better prognostic indicator as well, so being younger than 50. Some studies will say 65, under 65, but the majority of studies will look at AIS-C and under the age of 50. And then the initial level of injury is also important. So individuals with lumbar injuries tend to have more progression from complete to incomplete. And of course, that could be because more peripheral nerves are involved. It's not as much of a spinal cord injury. It could be more of a cauda equina injury at the lumbar levels. Individuals with cervical injuries have the next highest progression from complete to incomplete. And then low paraplegia follows, followed by high paraplegia. And the thought behind high paraplegia being the lowest recovery levels is that the thoracic cage of the rib cage provides so much stability to that spine that to have a spinal cord injury at the high thoracic levels indicates there must have been pretty significant trauma. And so that means a more significant injury. And then finally, the initial strength of muscles does help us with prognostication. Individuals, I believe the studies show that in complete tetraplegia, if anyone has a 1 or a 2 in the muscles below their level of injury, those are most likely to progress eventually to a 3. So as someone in their initial injury has 1s or 2s, that is a good indicator that they will get stronger. I have more information in the handouts. If you choose to download them, there's more information about prognosis, but hopefully this gives you just a little bit of a picture of how we use the INSCI diagnosis to also look at the literature and the database for recovery. In general, the most rapid recovery occurs in the first 3 months. then the majority of recovery after a spinal cord injury occurs in the first 6 to 9 months. We tend to see plateauing around 12 to 18 months, but there have been several cases, and more recently, for late recovery at 2 to 5 years. And this is especially the case for individuals with motor incomplete injuries. We're seeing that if you're familiar with the locomotor CPG that has come out in 2020, we're seeing a lot of more recovery with individuals with chronic injuries, more than 6 months. We're seeing increases in their neurorecovery with intensive locomotor training. And so that's exciting to see that it isn't necessarily plateauing as early as what we had thought. Obviously, the faster the initial recovery as well results in the greater overall improvement. There are some great prediction rules that have come out in the last 10 or 15 years. This is just one of them that I like because it's very easy in the clinic to take some of the diagnostic factors here and be able to plug them into this clinical prediction rule. So it relies on the factors that you see there, the age, and this one refers to over 65 years as a less of a prognosis of recovery. So if they're under 65, they get more points for that. Motor score of L3 and S1, as well as the light touch score of L3 and S1. You calculate the score, and then you put it into this graph. And so you can then predict if my patient has a 20 points on the prediction rule score, I can follow that up from the x-axis up to the y-axis and see that that individual is almost 90%, has a 90% probability of recovering some bit of walking by 1 year after injury. And so that's a really nice prediction rule. I don't typically share this data with my patient, but I use it to kind of have an internal thought process on what I might expect for my individual. So this gets to be challenging when we know the prognosis potentially, or we have an idea of the prognosis for a patient, and our individual wants to know, asking some really challenging questions. And so there is a study that indicates what some of the recommendations are for having these discussions with a person after their injury. And of course, they follow a lot of just general good bedside manner recommendations, some motivational interviewing type concepts as well. But the research showed that it's really helpful to know and to have this conversation as early after injury as possible. And the individuals preferred that it be a physician, or it's recommended that someone who has experience with spinal cord injury have this conversation, that they sit close, that they make eye contact, and use body language to convey warmth, of course. We all want to be person-focused and making sure that we're providing that compassion and warmth during a conversation like this. And then to speak slowly, deliberately, and clearly. That all makes sense. And that's great, but what do you say, right? I had to figure out what my answer was going to be to the individuals that I was working with. And I think sometimes we end up feeling like an individual could be in denial early in the stages after their injury and even into extended stages. And so that may not always be a bad thing. I've heard on our teams that sometimes that people are frustrated that they're in denial. They don't realize that their injury is severe as it is, and they only want to work on walking. And denial can actually be a protective aspect for our psyche during such a traumatic time. And so coming up against that denial is most likely just going to result in conflict with that individual and maybe not allow that teamwork that we need in the rehab setting. If they feel like I am not on their side, then they may not be as cooperative with what I am trying to offer them in their rehab stay. And so I want to make sure to give them space and maintain hope, because honestly, I can look at all these prediction rules, but I don't know what's gonna happen for this individual. Maybe they are AISA and they are going to be in the 3 or 5% of individuals who do ambulate. And so I don't want to take away that hope, and I certainly don't know. So I want to make sure to maintain the hope and be a partner with them. I'm going to give you verbiage as to what I've developed as my answer to individuals who ask challenging questions like this one. And I'm focusing this more on someone who isn't showing recovery below their level of injury at this point. So they may have an AISA level of injury, and they really aren't wanting to work on the things that maybe I would focus on in the early rehab stages. They want to work on their legs, and they really aren't wanting to focus on anything else at this point. And so the answer that I've developed has become an answer that I've given after I do an INSCI exam. That's often a time that's very stressful and very emotional for our individuals, because it's unfortunately pointing out all of the things that aren't present. And that's a really hard and emotional time for someone to have that pointed out to them where they can't feel or where they can't move. And so it often brings this conversation to a head very early on in the acute rehab stay. And so I've developed this trying to maintain hope and compassion, but also be on the same page as my team. So I've developed the answer that I will show you based on what our team members also are saying, so that when an individual maybe goes and tries to get a different answer from each member of the team, they're getting similar verbiage and similar language from each of us. And so my answer, and you're welcome to steal or develop your own, is when are we going to work on my legs? I want to walk. And my answer is, honestly, I really hope that you do walk. I would love to see that happen. Right now, unfortunately, no one in the world knows how to make muscles come back and work that aren't working on their own. But you are probably going to be one of the first person to feel those changes and know what's happening. And I want you to let me know so that I can help you to strengthen those muscles as they come back. In the meantime, we're going to work on getting in and out of bed, gaining strength, strengthening the muscles that you have, and focusing on the things that you need and want to do in the meantime. And so that really gives expectation. It brings hope, I hope. It allows them to be more in control and helps them to know what the next steps are. And so obviously an individual with more motor function, an AISC or D, we're gonna do a whole lot of intensity and a whole lot of getting them as upright and on their feet as possible. That's what the locomotor training CPGs are really showing us, that intensity, high intensity step training is really what's being supported in the literature. So we try to get them up in the acute phases as early as possible. But for those individuals that don't have that ability at this point, we want to be monitoring for that and watching to see when those things change. So in the sake of time, I think I'll continue on with the rest, but happy to have more conversation if we have some time at the end and answer any questions you might have there. We certainly have some comorbidities that we might need to watch out for. So as I've done my INSCI exam, I'm getting a picture in my head of what who this individual is and what their goals are. I'm wanting to get them out of bed and get them moving, and I need to be aware of some things that may come up for these individuals. So upper motor neuron injuries are a typical spinal cord injury. So injury to the upper motor neurons in the central nervous system. And so you can see there some of the complications that we find with individuals with an upper motor neuron injury. On the contrary, lower motor neuron injuries are basically those in the lower lumbar areas where we would see more peripheral nerve damage at the cauda equina. We can also see peripheral nerve damage in a brachial plexus injury, or maybe even some non-traumatic spinal cord injuries. You may see more of that peripheral nerve injury higher up in the cervical and thoracic, but typically these secondary complications are going to occur with those with a lumbar injury. So flaccidity of those muscles, less spasticity, and certainly some bowel and bladder complications and sexual function complications as well. I think most of us know that skin is a huge concern with individuals with spinal cord injury, and I would say much, much more prevalent than individuals with other neurologic diagnoses. We always think, okay, someone who has sensory impairments are going to be at risk for skin breakdown, but I will say that my experience individuals with spinal cord injury have much more fragile skin than even those individuals with brain injury. And so it's something that I think people underestimate if they're used to treating individuals with other neurologic diagnoses. They just aren't, those individuals don't have as fragile a skin as those with SCI. And I believe it's because of the imbalance in the autonomic nervous system. There's challenges in blood flow and physiologic changes that happen that make skin break down even faster. So anytime we see something like this, I'm extremely concerned, and we need to get the pressure off of that individual. Most likely, I would say this came from the bed, looking at this location of this non-blanching. And even if this is blanching, I'm still very concerned after spinal cord injury. And so this most likely came from laying flat in a bed or with the head of the bed too elevated with too much pressure on the sacrum. It could also come from sitting in a bedside chair or in a chair where they're sitting in a very slumped posterior pelvic position. And so we want to make sure we get the pressure off of that, because we could look at weeks and weeks of bed rest if that progresses. The autonomic nervous system, as I mentioned, becomes very imbalanced after a spinal cord injury, especially a spinal cord injury that's complete above the T6 level. And this picture, I think, explained to me in much better, easier terms what autonomic dysreflexia was, and finally had an aha moment when I finally found this picture. So you can download it and read it for yourself, but basically we have a sympathetic outflow below from T7 to T10. Most of the parasympathetic nerves, sympathetic nerves come out from T7 to T10, and so when there's an injury at T6 and above, we can end up with autonomic dysreflexia, which means very high spike in blood pressure that can be deadly. It is an emergent situation, and we need to get the person's head of bed up and get the whatever sensation is causing the pain, we need to relieve that. And so that's something to watch for in your individuals. They may show the typical textbook answer is they would have a headache. I actually find very few of my patients have a headache with autonomic dysreflexia. I see a lot more in lighter skin tones. I see a blotchy red rash. They may feel flushed or too hot in their face. They may start sweating above their level of injury, but it's very rare that they have a sharp headache like I learned in school. And so be aware of that flushed, hot, blotchy red rash feeling and get the head of bed up. We see certainly the skin issues and shoulder pain and wear and tear is a very common occurrence after spinal cord injury. So looking at seating and positioning as we're getting someone out of bed and able to be mobile in a wheelchair is really important. And so these concepts are all based on the PVA CPG, which is the preservation of upper limb function following spinal cord injury. And so I will just put those up there for you, and you can download this and look at that. Preservation of upper limb CPG is really helpful. You think it's focused on shoulder, but it actually does a whole lot more with seating and positioning. So if you're looking for a guide there, that's really a helpful resource. So we look at our individuals, getting them up into a ultra lightweight wheelchair when we can in our rehab setting so that they can start to be positioned well and prevent shoulder wear and tear. Also giving them the most ideal mechanical advantage and access to their push rims, which can be help with efficiency, being able to get out and about in their world, and also decrease any shoulder pain or injury. We need to do pressure reliefs and we look at propulsion. I won't spend time on that as I want to get into some of the videos that I brought for you, but you can see the details about what we would recommend or what's recommended in the literature about pressure reliefs. I have developed this functional progression over my 23 years of treating individuals with spinal cord injury, and it's really to help guide me and my students and therapists that are just learning what to focus on when. And so in the first column on the left, usually an individual who has fully innervated upper extremities, which is what I'll focus on today with our videos, an individual with a paraplegic level of injury, would be able to propel a manual wheelchair if they're set up appropriately. And then I would start working on balance, scooting, rolling, supine to long sit, all in the same sessions, trying to get more independence with that, those types of skills. And then I'm going to move into focusing my treatment sessions on the transfers, short sit to long sit, so leg management, and then floor to wheelchair eventually. And so that's the progression. It's not that I'm not working on transfers early on. I do the transfer to the mat, but I'm not having an individual who's struggling with balance and scooting, having them do transfers back and forth from mat to wheelchair or bed to wheelchair for the entire session, because they're just not ready yet for that. They don't have the foundational skill. And so I want to make sure that we get onto the mat or into the wheelchair from the bed and we work on a transfer very well assisted. And then I'm going to, as they get the techniques on the left column, then I'm going to say, okay, you have a good foundation for this, so let's work on transfers back and forth from mat to wheelchair. I want to see good mechanics because individuals who learn poor mechanics early on are going to struggle with the higher level skills. And so we always say practice makes perfect. Well, practice makes permanent. It doesn't necessarily make perfect unless it was perfect practice. And so in these skills, I really want to see that perfection and the good technique that they're learning, and that it's a motor learning technique. Every time they do a skill, it is creating a motor pattern in their brain, and I want them to use good technique. It flies in the face a little bit of those recommendations right now about high-intensity locomotor training, where the idea is just get somebody up and have them step, and it doesn't matter what it looks like. This is a little different, and what I'm proclaiming here, in that we really need to look at mechanics and skill, because we're basing so much of our treatment with individuals without the use of their legs. They need to use good physics and have a good mechanical advantage with their skills, so that's really important. So let's look at some movement so you can get an idea of what we're seeing in our individual with a T5 AISA injury. I'm focusing more on our motor complete folks because this is the most challenging type of injury to treat if you don't have the ideas as to what physics make these skills better. If you don't know where we're shooting for, it makes it really hard to teach someone how to do these skills. If someone has a motor incomplete injury, we know that we will be working towards walking with this individual, and we know what normal walking looks like, and we can progress towards that if they have the motor function to strengthen. But for an individual without lower extremity function, that gets really challenging to teach them to roll and do supine to sit and transfers with only the use of the part of their body that's innervated. So what do you see here as she's trying to roll? We see that the therapist is assisting and has kind of crossed her legs a little bit, but she's not being successful. He's needing to help her, and then he cues her right there at the scapula. And so she gets a little bit more success there, and I'm going to go on to the next one and show you this one. Anybody see what the difference is between those two videos? What is the success there? This is the same session with just a little bit of practice. What do you see is the difference? This is guided more towards therapists in the room. I heard it. Say that. The upper arm is going through more or protracting more, right? That upper arm gets in front of the lower arm, and her scapula actually protracts, which then tightens up the thoracolumbar fascia and the lats, and it brings her hips over. So the key for her is to protract. I'd love to see her head come up off of the mat. I would love to see her breathe out with a big breath that would collapse her thoracic cage and allow her to roll over her thoracic cage better. And I'd love to see just a little bit more momentum and maybe a little bit more flexion of the shoulder so that when she reaches up and gets more flexion, that also tightens up the lats and the thoracolumbar fascia, and she gets those hips over and won't need to have her legs crossed eventually. So this is an example of just the little physics and the getting your eye keyed into this movement, knowing what you're shooting for and how to make that easier. And so we were actually successful in getting her to learn to roll with her legs crossed after just a few reps. And eventually she would be able to, I would say within the next 2 sessions or so, she'd be able to roll herself over without having her legs crossed. So one example for rolling. You can see 5 weeks later, she's able to roll on her own. She uses a little bit of momentum. She's lifted her head just a little bit, which helps. She's protracting nicely, and she's able to roll independently. So for supine to sit, you can certainly roll and then come around, and I call this crawling to a C. So making a C out of his body, he crawls around. That's the easiest way to do it. But you see that Heather has also perfected the scap retraction method, and she'll do this again. So she's retracting her scapula, she's getting her elbows underneath her. Look at her using the momentum of her head and shoulders back and forth. So that she can get her elbows underneath her and then is able to sit up into long sit. Transfers. So she's gotten, this is actually her first day in rehab, and she's doing a transfer from the wheelchair to the mat. Now, those of you who have worked with individuals with spinal cord injury and know the mechanics of transfers, we love to see that head-hip relationship, right? The head comes forward and away from where their hips are going to go, and so we want her to be leaning forward and towards her push hand. So I'd like her head to come down and forward towards that push hand that's on the armrest there so that she can have the best mechanics. Unfortunately, watch what happens. She does lean forward, but do you see where her head goes? That wasn't exactly forward and away. Her head wanted to come up and back. And so she ends up needing a lot more assistance. You watch her, she's quivering, she's fighting what Daryl's trying to do there, and he's pulling her forward, and she is pushing backwards because she does not want to lean forward. There is a lot of fear of falling for our individuals with spinal cord injury and not wanting that forward lean. So I need to work on that with her to have more success. As she's scooting, notice that he's really encouraging that perfect practice. So making her come forward, telling her to bring her head towards that opposite knee or towards that opposite hand, and then assisting when she does that motion appropriately. Over time and lots of practice and combating fear, she ends up being more independent, able to place her own transfer board and able to complete the transfer with better mechanics. And eventually, I would love to see her be able to get away from using that board. That would be the ideal so that she doesn't have to carry it with her. She would be able to do a transfer without it. She's not quite ready for that. And so we'll see, notice she keeps her head down better towards her push hand and is able to have success with that scooting. Much more confident with her balance, able to manage the transfer board, and I think still needs a little bit of assistance there with her lower extremities. Oh, nope, she did it by herself there, so getting them off the foot plate. So more success. Now the next steps for her would be to practice lifting, so seated push-ups is where we want to go for an individual with a paraplegic level of injury, learning how to lift their hips off of the mat. And so oftentimes our individuals want to put their hands too close to the front edge of the mat because that's secure and feels stable. If their hands are in front of their hips and then they try to go and scoot, you have all this weight back behind their arms, and there's not a lot of success with that scoot, if you can imagine. So if I'm going to have success with scooting, I've got to get my hands back closer to my hips so that I have more of a mechanical advantage to actually slide my hips to the side. So we need to get his hands back by his trochanters. What we're looking for is some nice scap depression. I want him to tuck his chin so that tightens the thoracolumbar fascia there, and we see that last little effort right there was successful. He is not able at this point to get enough lift. You can see him trying to hop or throw himself forward, and so he needs more scapular strength and stability in order to do this lift. We'll show you here, this individual, she is working on this same technique where she's lifting, but you can see she's gotten a little bit more success with the lifting. She can lift her hips and scoot. I love to really drill in a lift, pivot, and sit, or up, over, down, as we call it, either one. And I call that the staple maneuver because it's like a staple that hasn't been stapled yet, right? So you want them to go up, over, down, and as they get that motion, then you can round that out with momentum. And so then they can lift and pivot without having to be so exact about the staple. If we cheat this, I will tell you my learning moment. If you don't insist on the lift first, then the pivot, then the sit, you will regret it because they will start throwing themselves from one surface to another. So they'll just throw and pivot without the lift. And then when we're going from a chair that's lower than the bed, and they just throw themselves to the side without the lift, your pelvis hits the bed, the chair moves out, and you end up on the floor, right? So I have found that if I don't really drill this lift, pivot, sit, then I am regretting it later because they haven't learned how to get that lift first. You can see that she, you can see that she still needs him to block her knees and help her just a little bit with the lift. So my assessment of this video is that she needs more scapular strength and scap depression strength, which I love. Does anyone have a rickshaw machine in your facilities? Do you know what a rickshaw is? Pushing down the weight machine where you back into it maybe in a wheelchair or pull in forward and you do depression lifting. I see maybe a couple nods. It's my favorite. So if someone is looking like she is, I want them on the rickshaw getting that depression strength with their shoulder blades coming down away from their ears so that they can get that strength to be able to lift their body and be able to do this maneuver. You need to be able to depress about 50% to 2/3 of your body weight in order to do a transfer without the board, especially from the floor to the wheelchair. So this would be the goal, is what Eli is doing here from a lower mat up to a chair, using some momentum, but he's getting that lift first. He's not just throwing himself into the chair, he's getting a nice lift and able to sit himself in one movement up into his higher chair. And then you can see Zach doing a great job with going from his wheelchair all the way down to the floor, even with a CTO brace on and using great body mechanics, his head-hip relationship there to get himself to the floor. And then you'll watch him bring himself back up again. Using the same mechanics, head comes down towards the push hand, and he just pivots himself up into the chair. If he is not good at doing the transfer that Eli's doing on the left side, he will not have success with that floor to chair transfer. He needs to know those mechanics and be really comfortable with basically ducking his head down to his knee while he's pressing and getting himself up into the chair. And then, of course, this translates to being able to do a low to high transfer into an SUV or a truck. Plenty of our patients will want to drive a lifted truck or SUV, which can be challenging on the shoulders, but possible with good mechanics. And so this is just a YouTube video that you could search for to show individuals how to do that transfer from low to high. And then finally, wheelchair skills. We're typically working on these at Craig Hospital throughout an individual's length of stay. And so you can see this is an outpatient who has come back to see us, being able to do wheelies, curbs, little steps individually, and then he drops off our 8-inch curb that's in our terrain park. We teach this skill on the right side of the screen for individuals who maybe don't have a fire escape other than, or an accessible entrance. They can get down some steps with a railing. And so this is actually quite an easy skill. It looks scary, but it's quite an easy skill to learn, where an individual drops down the stairs backwards using a railing. I would recommend that the individual have great hand function. When you're doing this, do not do this with an individual without good grip strength. You'll be sad about that. And then this just shows how we teach individuals to be able to get in the door from their wheelchair. And this is slow motion. He pulls back, turns his wheelchair into the door frame, and then uses the frame itself to pull himself through. So, lots of skills there that we hope that they learn on the acute rehab and into your rehab stay with the individual. And then that will allow them to get back to some of the activities that we heard about earlier today from our rec therapists, that we can get them out into the community, have them safe and confident and effective in being able to get back to activities that they want to do, either newly learned activities or previous activities that they wanted to re-engage in. So very important for us to be able to get out and about and apply what we're learning in PT. Now, motor incomplete injuries, I wanted to address in here as well, because we tend to see the most of our individuals with spinal cord injury have a motor incomplete injury these days, which is a great trend that we're seeing over the years. When I first started teaching, that was not the case. And as I looked at the graphs and the data that was changing, it's very exciting to see that we have more and more incomplete injuries. And we're attesting or believing that that is because of our science and technology within our cars, since 40% of our individuals with spinal cord injury are injured in a motor vehicle accident. So it's attributed to having better technology and safety in our cars, as well as better emergency response awareness to cervical spinal injuries, and brain injury. And so we're just better at in protecting that spine and seeing more incomplete injuries, which is wonderful. Now, I'm not spending as much time on the incomplete injuries because that is a little bit more straightforward. Whatever they have in their body, let's use it and let's get them up and moving as much as possible, challenging them with higher level skills than what we think they can manage. If we can use body weight support, I highly recommend it. It will save you and it will make the patient more confident if they know that they're strapped in. There's a lot of fear, as I mentioned, in our complete injuries as well as our incomplete injuries. There's a lot of fear of falling, and this may come from PTSD, from the way they were injured, or just that lack of control of their own body. So how do we create more stability and more confidence? We can do that with some body weight support if you have it. And I think in my tour yesterday, I saw a light gate, and a light gate over a treadmill can be just a very easy, simple tool to get someone up and feeling more confident. So you'll see some video here of what we're using to get those individuals up. If we can't get someone up, we need to build a foundation of stability, lower extremity and core strength, and tolerance to upright first. And so with my individual that you'll see here, poor Caden was 15 years old. He had a C5 in ski level. He came to us as AIS-B, and so the predictability of him being able to convert to C was higher, and he did. He started to show us lower extremity movement within the first week that he was with us. And that was very exciting. So he had a little bit of quad, a little bit of adductor, and unfortunately, he had lots of blood pressure issues. So that's another complication that we tend to see. He could not keep his blood pressure up to save his life. He was struggling. And so here he is tilted back on our bridge, just trying to maintain his blood pressure. I think we were giving him fluids at that point, just to try to help with that. But he was 6'3" as a 15-year-old and about 125 pounds. So tall and lean. And you can see that I was just trying to get him on his feet right by the mat because he would just get dizzy so quickly that I needed to have him sit as quickly as possible. We were able to progress to getting him up with some body weight support. And I love this Arjo walker that he's using here, provides a little bit of stability for him. He can weight bear through his elbows, and I can assist him from behind. And so this was a great way for us to get him up. If he got dizzy, I could lower him down and he could just sit on my lap while he recovered, and we could get his chair for him. But we struggled a lot with blood pressure with him. So I did actually do a lot in tall kneeling and developmental sequencing and things like that, to try to get him stronger, and he could tolerate that a little bit better with his blood pressure. We can see here that we've progressed now to a regular walker. We were doing a lot of intensive standing and ambulation with some body weight support, but you can see he's a little more stable. He did not have triceps. That's why his walker is just so low. Those of you looking at it saying, why is his walker so low? He didn't have triceps, so I had to have him lock out his elbows so that he would have some support there. And he was able to then, at this point, take steps more on his own. As you can see, without any facilitation, needed some bracing there, and so we progressed him using, this is a Locomat without the robot, but this would be simple to do over a treadmill with a light gait or over ground here. So we continued to progress, had him ambulating in the pool with weights on his lower extremities, and over time he was with us for about 6 months in total. He was part of a research program, so he stayed with us a little bit longer than typical. But he was able to progress over 6 months to what we'll see here. Oh, yeah. So you can see then in outpatient, he started working on faster ambulation. He has gotten away from using his assistive devices, and ultimately he's able to do some running and jumping. And so this was a video I needed to, I had a bookmark on there to be able to advance it to the end, but we'll let it just play. So individuals with incomplete injuries, again, if you feel like you are not doing enough with them and you could treat them for 8 hours a day, you're doing it right. There's so much to do with our individuals with incomplete injuries and trying to maximize their return. And I think when I first started working in PT, it was the thought that you needed to gain the strength first before you could get them standing. And what we're really seeing now in the literature and in my practice is if I challenge somebody and get them on their feet before they're ready to be ambulating, then they're actually taxing the rest of their body and their nervous system. And we see a better carryover from stepping and walking with assistance to being able to do transfers, to be rolling in their bed, to do supine to sit. And so the more we're taxing and challenging that nervous system, the more recruitment we see from the rest of the body and the better carryover that we see in the wheelchair level skills. And so I like to, it's called reverse transfer in the literature, and to be able to really tax someone that way and challenge them with upright activities. It may not be what I do for the entire session, but I will do some standing when I can with body weight support, and then work on those wheelchair level skills after that. So there's some priming of the system and use of motor learning techniques and concepts. So you'll see at the end of this video him doing more of his plyometric training and where he's come. Some things to consider long-term for individuals with spinal cord injury, certainly as individuals age or have, if we aren't protecting their joints well enough, we start to see failure of joint capsules, we see arthritis, we see wear and tear of the joints, and so we need to be very careful about that. And then also as individuals age, we do see an increased fragility of their skin, wear and tear of their shoulder joints as they're using them more extensively. And so all these things we need to be aware of, and making sure that we're monitoring them on a regular basis and making sure we're addressing these concerns that come up with aging. There he's showing his tenodesis and ability to drink from the water bottle. And you'll see that at the end. So I'll open it up for questions. If anyone has some, I think we have a couple of minutes. Abby, is that okay? And so happy to entertain any questions or comments or your experiences that you'd like to add in. And there he is running off into the distance. And go ahead.
I'll come over with the mic so our friends virtually can hear.
Oh, great, thank you.
So I'm a physical therapist, and we have problems with people being on spinal precautions. You can't twist, they're gonna wear their TLSO the whole time. They're on rehab. What are your suggestions to getting away with, getting protraction, retraction without doing twisting?
Yeah, that's a great point. Thank you for bringing that up. We also have patients come out of acute inpatient stays in the acute care with bending, lifting, twisting. And our physicians have talked with surgeons and have basically cleared us to do anything that we need to in rehab within the confines of their brace. Now, that has been a lot of conversation with the surgeons, and certainly please don't go back to your facilities and say, Laura told me not to follow my precautions. Please follow them. However, we have never found any problems with anyone doing any sort of rolling like you saw Heather doing in the beginning. Most of our patients do have a TLSO on, and we are doing that rolling with the TLSO in place, fitted well, tight, worn tightly, not the way the client wants to wear it, but tightly. And we have not seen any issues with flexing beyond 90, rolling while in the confines of the brace. What we don't do while they're in the brace is transfer all the way to the floor. We do, short of that, we don't do any lifting and loading with rotation, so loading their wheelchair into the car. We don't do any of that. But we are cleared to not have precautions. When you're restricted to a 90-degree precaution at the hip, right, I don't know how we do rehab, right? You can't even lean forward to get a sling behind. And so it's really challenging. If you really are restricted to 90 degrees, it is very challenging. I would ask questions. I would say, we need to be able to lean forward in order to transfer. I need to be able to lean them forward to get the sling. Is that okay? And when I've asked questions like that, I have had, in some cases, some success in they're like, oh, well, yeah, if they need to be able to do that to transfer or to get in and out of bed, then absolutely, go for it. We had a restriction when I first came to Craig that you weren't allowed to go prone with a collar on, for example. And so I found that very challenging because I really want to be able to do protraction in prone on elbows with my individuals with a C6 level of injury. So I was struggling to get success with those patients. And we started asking questions, and the physicians said, oh, well, you want to get prone in therapy and stay in alignment like this in a collar? And I said, yes. And they're like, oh, we thought you wanted to turn and lay prone with the head rotated. So we don't want that, but you can go prone. And so it was one simple conversation. That's a lie. It was several conversations that ended up being a simple answer of, oh, okay, if that's what you needed, I understand. And yes, within therapy, you can get them prone. They can't sleep prone, but they can be prone while in therapy. And so I would encourage you to ask questions and see what you can get. But I agree that when you have spinal precautions that are being held rigidly, that's a challenge. Okay, am I getting pulled off the stage soon? Do we have any more questions? I'll be here today. I would love to chat with you if you have other questions or examples. Thank you so much for your time and attention. And my email is at the beginning of the presentation. Please feel free to reach out if you have any follow-ups as well. Thanks.
Thank you so much, Laura. We're only 2.5 hours in, and I feel like we've had a full day of education so far. We're going to do something a little different this year on our breaks. We're going to, if you turn your folders over, you have numbers on them. And I'm going to draw a few numbers, and we're going to get out a few goodie bags. So number 115, number 83, and I should have mixed these up better. Number 57. If you won, come on up and grab a goodie bag. We are going to take a 15-minute break now. Do be sure to be filling out your surveys in your packets. They are on the yellow papers. We will collect those at the end. Please go visit our vendors. You have a bingo card. We're giving away a free registration for next year's conference.